Hey guys, this is your Chapter 13 Patient Assessment Lecture. This is actually broke up into two parts just because this chapter is huge. So I'm ready to get started. I actually have my book right down here with me. So if you see me looking down, that's because I'm reading along with y'all. So starting off with our introduction, one thing we need to do is make sure that this is a seamless process. To our patient, it should look like we know exactly what we're doing, which, be honest, we all know that we don't. It's mostly a blended answer question. We should be going off of the patient's answers and building questions off of those. But the assessment should always be seamless. If it's not seamless, it should just seem like it is. We do not have as many diagnostic tools as hospitals do. So it may be a little bit more difficult for us to catch some things, such as fractures or breaks or get those lab values. We don't have those tools. We don't have CT scanners. So they're going to be able to catch a lot more things than we can, but our assessment should be just as great. And we need to know that there are different stages of an assessment, which we're going to go over here in just a little while. The first thing we need to do is we need to differentiate sick versus not sick. So first, look at your patient. You can tell when somebody looks terrible. Like if they look like they're about to die, they probably are. So then we need to determine how sick is the patient. So we're gathering this just by looking at them. We always want to qualify and then quantify. Is the patient sick? How sick? So establishing the field impression. So this is based on our history and chief complaint. This is when we put all of this together and get our field impression. So we need to gather this quality information, such as their educational background, their cultural background, their ethnic background. Cultural being religion. Some religions have different medical practices that they will and won't do. Their ethnic background. It may be that one ethnicity is more prone to a different disease than others. And we always need to ask questions based off of previous answers. So if your patient has tells you that they have diabetes, well, the next question should be, do you check your blood sugar often? Do you take any medications for that? So all of our questions should be based off of those previous answers. So medical versus trauma. These are the two basic categories that we put everything in. So on medical, we need to identify the chief complaint, and then we need to be sifting through all of their medical history. Their medical history is going to give us the best idea of what's actually going on with the patient. And then trauma. This is usually an unexpected event that happens. So there's going to be a much different approach to this assessment. So, and our history is going to play much less of a role in this process. We need to know that medical can cause trauma. So your patient has a low blood sugar and they fell. They hit their head when they fell. So medical can cause trauma. Okay, so this is the way that we should set up every assessment that we do. So the first thing we need to do is our scene size up. Then we'll go into our primary assessment, our history taking, and from there we need to decide if this is a medical or a trauma, and then we'll go into our reassessment. So we're going to go over each of these in detail. We're going to start with scene size up. So the big things here, we need to make sure we ensure scene safety. We find out their mechanism of injury or their nature of illness. We take our standard precautions, get our number of patients, and any additional resources. So for the scene safety, so we need to ensure that the scene is safe for not only us, but our partner and our patient. But most importantly, I'm most important, and then my partner, and then the patient. If the scene is not safe, do whatever you need to make it safe. So is there a dog? Can we get the dog put away somewhere? Is there a active shooter? Well, I'm not going to go in. I'm going to get law enforcement there. Whatever I need to do to make the scene safe is what I'm going to do. So, mechanism of injury or nature of illness. So, mechanism of injury is the way in which a traumatic injury occurs, and it helps determine what injuries the patients will have. So, examples of mechanisms of injury would be patient rolled their vehicle, or patient fell down the flight of stairs, or patient jumped out of the second-story window, not roof. And then nature of illness. This is the general type of illness that the patient is experiencing. It can be gathered from the patient or the patient's family. If the patient's responsive, we want to get it from the patient. If not, we can get it from the family. So for standard precautions, of course, make sure we wear properly sized gloves. The too small ones can rip really easily. Too big, you're going to get grossness up underneath your gloves. Protective eyewear if needed. Anytime you're intubating somebody, you should have protective eyewear on. Wear a HEPA mask, N95 mask if need be, and possibly a gown. If they're squirting blood or they're actively delivering a child, we're going to need a gown. So that was it for our scene size up. Remember, we'll need to do additional resources also. So if your patient has, if they would need air medical, if you need the power company for down power lines, hazmat, anything you may need, that is the time to get that. You're also going to determine your number of patients. So if it's a car wreck, you may have multiple patients. But if it's just a single medical issue, it's probably just going to be one patient. So next up is our primary assessment. This is the most time-intensive portion because it focuses and identifies those life threats. Here's where we are going to be forming our general impression, getting our level of consciousness, identifying the life threats, and determining our patient priority. So, for our general impression, we need to make observations about the patient. So as soon as we walk up to this patient, I want to know, is my patient sitting or standing? How are they standing? How are they sitting? Are they tripoding? Are they laying supine in a bed? I also want to know the color of their skin. Do they look pale? Do they look red, like they're really flushed? Are they overweight or are they thin? Are they smiling? Are they frowning? There's a lot of different things that can go into when you just look at a patient. Here we also want to look for clues on how serious the situation is. Again, if your patient looks like they're dying, they probably are. And does my patient look stable or unstable? Next, we want to determine their level of consciousness. So we're going to be doing this by the AVPU mnemonic. So are they alert? Did they notice when I walked in? Are they talking to me? Is everything good? Are they unresponsive unless I talk to them? And if I do talk to them, are they responding appropriately? Are they just moaning? What are they doing? Do they respond to pain? Don't do the sternal rub just because you have chances of hitting that xiphoid process and you could break it off, or just breaking a little bone off, especially in the little old ladies with osteoporosis. So they're now recommending the trapezius pinch. So pinch here. Again, do they respond to that? Will they start talking to me for a while, or are they just moaning in pain? And that should not say verbal, that should say unresponsive. So the last one should be, are they just unresponsive? They don't respond to pain at all. Are there any changes in their LOC? As in, is this a normal LOC for my patient? This is a good question for family members. If they don't know all the right answers to their person, place, time, and event, is this normal for them? Sorry, I got a little lost there. So next we want to assess the airway. So we want to know, is my airway patent? By patent, I mean they're free of any obstructions, they can breathe normally. Non-patent would be snoring respirations, gurgling, or any foreign body obstructions. So for snoring, we want to manually open up that airway, provide the BLS maneuvers. That basically snoring is tongue is back on their throat. And then gurgling is going to be some type of fluid in the airway, more than likely blood. So we want to suction that. And any foreign body aspirations, we want to use BLS techniques to get that out. Next, we're going to assess breathing. So we want to look at their tidal volume. Is it slow? Is it fast? Deep? Shallow? When we get into airway, we'll go more over tidal volume. Breathing rate, we want to look at fast or slow. We don't need a number right now, just fast or slow. We want to look at their work of breathing. Are they using any accessory muscles, as in do they have retractions? Accessory muscle use would be up here, the neck muscles, or in between the ribs going in and out. And does their chest rise and fall with symmetry? We move on to circulation. Here we're going to check their pulse. In a responsive patient, we want to check at the brachial, the radial, and on an unresponsive, we want to check at the carotid. Again, we want to know, is it fast or slow? Right now, we really don't need a number. Is it thready? As in their pulse never really seems to end. It just kind of draws out the whole time. Is it bounding? Do they have a huge pulse that would say they are hypertensive? Do they have a pulse at all? We also want to note the rhythm of the pulse. Is it regular or is it irregular? That's important later on when we get into cardiology. We also want to know the color of their skin and the temperature of their skin. One thing to note on the primary assessment, if you find anything wrong with their airway, their breathing, or their circulation, you want to correct that as soon as you find it. So any life threats that come during airway, breathing, or circulation, correct those as soon as you find them. So here, if we have not already done so, we need to control any of our major bleeds. Restoring circulation. If the patient doesn't have a pulse, start CPR, get your AED out. And then we need to assess the reason for low circulation and correct. Are they just hypotensive because they are in a trauma accident and they have bled out? If so, we need to get an IV started and get them some fluids back in there. If they have low BP because they've taken a lot of beta blockers, we need to correct that also, which we'll get more into in the medical chapter. Any patient with poor circulation should receive oxygen. Any patient with poor circulation should receive oxygen. So treating our life threats, again, they should be treated immediately as they're found. And this is the entire purpose for the primary assessment. We want to make sure that those life threats aren't going to kill them right then. So airway, breathing, circulation. If there's anything wrong with those three, immediately treat them. Assessing for disabilities. So we need to do a neurological evaluation. This could include pulse, motor, and sensory of each extremity, arm drift, grip strength, and sensation. So basically here we need to do a Cincinnati stroke scale if we believe our patient is having a stroke. Exposure. You cannot assess what you cannot see. So our patient needs to, if they're a multi-system trauma, you need to be able to assess every part of their body, which means cutting the clothes off. Some things that we need to be aware of is the weather. Is it really, really cold outside, like snowing? That doesn't happen in Texas, but it could happen other places. What does happen in Texas, though, is it's hot. It's really hot here. And the asphalt here is really, really hot. And so if your patient is a trauma patient and you lay them down on that hot asphalt, they're going to get burned. So pay attention to your weather and what's going on around you. Also, for exposure, be aware of bystanders that are around. Always try and cover your patient up whenever possible. Don't expose them in front of others. And then worry about the age of your patient too. So if you're in a high school or a middle school and you have to expose your patient, don't do it in front of the entire class, because how embarrassing for them. They're so body conscious that we really need to make sure that we are respectful of that. If you absolutely have to, then you have to. But if there's any other option, take it. So next is our rapid exam. So instead of just telling you how to do this, I actually have a video, but there are some things that we need to go over first. So the first one is inspection. This is simply just looking at your patient for abnormalities, for asymmetry, anything that may indicate a problem. So inspection is what you can see. Then there's palpation. Palpation involves actually touching, feeling, and moving these parts. Any bones, musculoskeletal, their head, their abdomen. So palpation is what you can feel. And then there is auscultation. So this is what you can hear. So we're going to auscultate breath sounds. We're going to auscultate heart tones. We're going to auscultate the blood pressure. Some people like to auscultate bowel sounds if need be. So here is the video of that. So I'm going to let y'all watch this for a quick second.
Palpate the head, the face. I will check her pupils. What do her pupils look like?
Equal and reactive to light.
Awesome. Inspect the ears. Do I notice any fluid coming from the ears?
There's no fluid coming from the ears.
Okay. I already inspected her airway. Neck. I'm going to palpate her neck, check for JVD or tracheal deviation. Do I notice anything in her neck?
No, you notice nothing.
All right, chest. I'm going to inspect for equal rise and fall. I'm going to palpate her chest. Okay, patient again responds painfully to palpation. Does their chest feel stable though?
It does feel stable.
Okay. Moving on to the abdomen. I'm going to palpate the abdomen.
It is soft.
Soft, not
in all
tender?
quadrants.
Okay, awesome. Pelvis. I'm going to palpate the pelvis.
Pelvis is stable.
Okay. Moving on to the legs. Palpate the upper legs. All right. Patient responds painfully to palpation there. I'm going to go ahead and straighten this out. As I inspect this leg, what do I see here?
You see a deformity to the lower leg.
All right. Deformity to the lower leg. And how about this over here?
It's normal.
Normal. Okay. So I'm going to assess pedal pulses. Do I have pedal pulses?
They are present.
Okay. Normally I would do a complete CMS check, but since my patient isn't really responding to me, I'm going to I know I've got pedal pulses. Same with wrists. Do I have full circulation up here?
Both pulses are present.
Okay. So I've got a head to toe done.
So that concludes our rapid exam. We're going to go over some more of this in class too, so don't worry too much about it if you didn't get it all. So at this point, we need to make a transport decision. What hospital with what specialties are we going to take our patient to? So if they're having a stroke, it needs to be a stroke hospital, so they have to have a CT scanner. If it is a multi-system trauma, we need to take it to a trauma hospital. If it is a heart attack, we need to take it to a place with an interventional cath lab. So when we make this transport decision, our patient is a priority patient if there is absolutely anything wrong with our A, B, or C. So A, B, C's are off. Hey, this is a priority patient. It's going to a level 1 hospital. Next, we're going to move on to our history taking. This is the really fun part. So, here we're going to get our chief complaint, our sample, and our OPQRST. So, The purpose of this is to learn about the history surrounding the event. We want to make sure that we ask open-ended questions to our patients. And we also want to make sure that these questions are age appropriate. So if you are asking a question to a 6-year-old, you want to make sure not to use big medical language. So, patient information. We, of course, need to get their name. We need to check out their responsiveness or their orientation. So we need to ask them the day of the week, time, location, and events. We also want to know who called 911 and why did they call 911. Was it the patient, or was it a bystander or a family member? And if another EMS is already on scene, what information do they have? Did they see something different? Did they already gather those medications for us? Did they talk to the family members? Techniques for history taking. So we need to make sure to establish a personal relationship with our patients. I'm going to get there. Give me a minute. So we need to make sure to establish a personal relationship. We're usually with these patients for a very short amount of time, but it's amazing how far a smile and just being nice can take you. So your appearance and demeanor. We need to be clean and neat. If you look put together, your patients will trust you more. Don't go in there with your boots unzipped, boots tucked in, haven't washed your shirt in 3 days, spilled some ketchup on it, haven't washed your hair. If you just look a mess, your patients aren't going to trust you. So you must be calm and collected, even if you're not. So if you are freaking out on the inside, hold it together on the outside. Be like a duck. Swim like hell underneath, and on the surface, you're calm and collected. So make sure you're also professional to every patient. I don't care who it is. They could be the worst person in the world. You're still a professional. So make sure every patient is treated with respect and we're professional to every single patient. Try to interview your patients in a private setting. They're more likely to give you information if they're not surrounded by all of their family members. Especially if you have a 16-year-old girl and you want to ask her if there is a possibility that she could be pregnant, I can guarantee you she's going to lie in front of her dad. So try to get these patients in a private setting. Confidentiality, basically we just need to remember our HIPAA rules. Don't tell anybody who doesn't need to know. So how to address the patient. Use the patient's name or ask how they would like to be addressed. Use Mrs., Mr., Miss, whatever. Always err on the side of caution for that one. Avoid the use of pet names such as sweetie, honey, buddy, any of those. Unless they tell you that's how they want to be addressed, I would avoid it. So, retrieving or reviewing medical history. We need to look at our source of information. If the patient is giving us this information, it's probably reliable. However, an immediate family member, probably reliable. The further we get away from the patient, so great niece of a friend of the family, she's probably not going to have very reliable information. Immediate family or law enforcement are usually the best source of information. Immediate family for your medical patients, and law enforcement probably for your trauma patients and your wrecks. So our responsive medical patients. Your field impression will usually come from the history taking portion. So we need to be really good at history taking. Make sure your patient is comfortable. If your patient isn't comfortable, they won't trust you and they won't tell you anything. So your chief complaint. This is always recorded in the patient's own words. If the patient says, "My head hurts," write in quotation marks, "My head hurts." And unresponsive is an appropriate chief complaint. So if your patient is unresponsive, Unresponsive is their chief complaint. And my least favorite chief complaints are the patients that say, I just don't feel good. Well, I know you don't feel good. That's why you called me. But we need to figure out what the root of the problem is. Are you having stomach issues? Are you having respiratory issues? Cardiac issues? So we really need to narrow down on that chief complaint. History of the present illness. OPQRST. Onset. So what were you doing when this started? Provocation. Does anything make it better or does anything make it worse? Quality. What does it feel like? Don't give your patient options on this one. We want to know, is it a sharp pain? Is it a dull pain? Does it feel like an elephant is sitting on your chest? Region, radiation, and referral. What I like to do is I say, can you take one finger and point to where it hurts? So if they can point right here, it does not radiate. But if they do this, then it radiates. Severity, on a scale of 1 to 10, 10 being the worst pain you've ever experienced and 11 is not on this scale, rate your pain. And what time did this start? Our other one that we need to get is our sample history. So any signs and symptoms, any allergies, any medications that they take, past pertinent medical history. I don't care that 15 years ago they had a nose job. Don't care. I want to know if they have diabetes or they have pneumonia, if they were recently diagnosed with cancer, any of those things. I also want to know their last oral intake and the events leading up to this event. The events leading up to right now. Were they sitting on the recliner? Were they eating a bag of chips? Were they running a marathon? Were they just driving to work? We also need to look at our patients with those multiple complaints. Which one is most important? Do they all tie together? And which one's currently going to kill my patient? Also look for any medical tags that may be on your patient. A lot of times they're wearing a necklace or a bracelet. So now their past medical history. Remember that we want their pertinent medical history. We want to learn about any of their chronic issues that they have. Knowing that the patient's condition may get worse from those past issues, or it may stem from those past issues. If they have diabetes and they're unresponsive, I'm definitely going to check their blood sugar. Are they currently being treated by a physician for any illness? What is their treatment and are they compliant? So do they have a pneumonia and they were given antibiotics and are they taking those antibiotics? We may need to filter the patient's responses. Like I said, I don't care if 15 years ago you got a nose job. We need to keep them on track to get what information we really want. If they had any past surgeries, including cardiac being our big one, do they have any stents in? But any past surgeries. And past hospitalizations and disabilities from a previous illness. So did they have a stroke and they have disability on the entire left side? Is that paralyzed now? Or they're having an asthma attack right now. What happened last time you had an asthma attack? Did you go to the hospital? And were you intubated? Because if they were intubated last time, it's a pretty good chance they're going to get intubated again. And do they have any mental health problems? Not just your big ones like schizophrenia or my mind totally just went blank. Schizophrenia or, whatever else. I'm talking about little ones too, such as depression. That's a mental health problem. And how were these past issues solved? Are you on any medication for your schizophrenia? I also want to know about their current health status. So this ties together their past and current history. So I want to know if any medications they're on, any allergies they have, do they smoke, drink, or do illicit drugs? When you're asking about drugs, make sure that you have confidentiality. So tell the patient, I'm not a cop, I don't care what you do, I just need to know what drugs you do. And anything else you can think of. Do they take any over-the-counter medications? What have you eaten today and yesterday? Are your immunizations up to date? Do you exercise? Do you have a history of any specific diseases in your family? My favorite one on here, it says, are you an optimistic person? And I don't think I can ask my patient that. It says, you might feel it important to get your patient's overall outlook on life. Yeah, no, I'm good. So next is their family history. This will just determine their risk factors. A lot of times family history doesn't have a whole lot to do with it, but if their dad died at the age of 35 from a heart disease, they may have a higher risk for that heart disease. And not every aspect is important. Also want to get their social history. This typically is not gathered in pre-hospital, but we can ask things like smoke, drink, do they do drugs, how much they like to party. And sexual habits, don't ask this unless you absolutely have to. And their diet, how much do they eat, what do they eat? And I'm not just talking about the overeaters. I want to know also about the patients who don't eat enough. What do they normally eat on a daily basis? I also want to know about their occupation. Are they working around chemicals all day, every day? Their environment, again, those chemicals, travel history. Are they going to do they have a disease that we typically don't see here that they've gotten from another country? Okay, so our unresponsive patients. On these people, we must rely on a head-to-toe assessment. They can't tell us anything, so we have to figure it out on our own. So, again, immediate family or law enforcement, usually your best bet on information that you need. Okay, so for our trauma patients, a number of mechanisms have the potential to produce life-threatening injuries. So what I did is I pulled the STRAC, South Texas Regional Advisory Council. That's kind of what we fall under. They made up a criteria whether they're a trauma alert or not. So you can see that one red or two blues make this patient a trauma alert. One of the reds, no radial pulse, heart rate less than or above 120, loss of sensation, suspected spinal cord, two or more long bone fractures on different extremities, or two pregnancy, fall from 20 plus feet, death in the same vehicle. Any of those will cause it to be a trauma alert. Again, with the same thing with PD patients, and their definition of PD is under 16. Okay, so our trauma patients. So we need to be really cautious of these people with MOIs, multiple MOIs. So a lateral collision that leaves the patients with a crushed upper arm and pelvic girdle. Also penetrating trauma from a piece of door trim impaled into the chest. These patients will have an increased chance of a very fatal injury. So these multiple MOIs we really need to be careful about. We need to check and see if these patients were wearing seatbelts and airbags, and if they did those cause any injuries? If they didn't, were they ejected from the vehicle or were they just thrown around? We need to look and see if child seats were used. One of the scariest feelings in the world is looking into a into a car that's been in a wreck and seeing a child seat in there, but no child. So if you see a child seat, make sure you find the child. Or if you don't and there's a child around, you need to start doing some investigating there. So for our minor injuries, I'm talking about those isolated injuries. A lady stepped off the curb and broke her ankle. She didn't fall, she caught herself, and then sat down. we can really, got lost again, we can really just really focus on that isolated injury. We don't need to do a whole head to toe just because we know that patient doesn't have any other injuries. All right, review of body systems. So we need to be looking for our pertinent negatives. So pertinent negative is something you would expect to be there but isn't. So your patient has myocardial infarction. So you know they're having a STEMI, but they're not having chest pain. That would be a pertinent negative. General symptoms, again, your sick patient calls. We really need to sift through all of this and figure out what's going on with this patient. With our skin, hair, and nails, on the skin, we need to look for those rashes. We need to look and see if they're sweating. Should they be sweating and they're not, or are they and they shouldn't be? Hair loss and hair growth. We need to ask our patient if they have any hair falling out, if their hair seems to be growing more than normal or not growing at all. Same thing with the nail. We need to ask about nail growth, any striations that come along with those nails. Any of these things, the hair loss growth, the nail growth, that can indicate some type of endocrine issue. All right, musculoskeletal. Pain, loss of sensation, motor. So we need to ask our patients, are they having any pain at this area? Can you feel me touch down here? If the fracture's here, can you feel me touch here? Motor, can you still move that arm? Ask about range of motion. And we always need to be suspecting of the little old ladies that may have osteoporosis. Moving on to head and neck. Severe headaches should always raise concern. Severe headaches, loss of consciousness, they could be potentially life-threatening conditions. Eyes, ears, nose, and mouth. We need to ask about vision, ask about hearing, nosebleeds, loss of smell. So when we ask about vision, we need to see if they can, they've been seeing spots, or has their vision been getting worse? When we talk about hearing, has your hearing been getting worse, or did it all of a sudden go out? For their nose, of course, nosebleeds, loss of smell, any pain. Again, we're just asking about all of this. We also need to ask about throat and mouth issues. So any pain when swallowing, any difficulty swallowing, any pain in the mouth, any lost tooth, swelling around the neck, swelling of the tongue, any of that we need to ask. All right, so endocrine. Enlarged thyroid gland. Normally, for very enlarged thyroid glands, we can see that. But if it's just subtle, the patient may have to tell us. What we'll notice with these are your temperature intolerance. They get so cold so easily. Skin issues, dry skin, real flaky. Weight changes. Either they're losing a whole bunch of weight or they have gained a whole bunch of weight. Also, it could be polydipsia, which is increased thirst, polyphagia, increased appetite, or any changes in the body or facial hair. All right, chest and lungs. Always, always, always screen for dyspnea and chest pain when we're examining the chest and lungs. Have you had any shortness of breath lately? Have you had any chest pain associated with that? Coughing, wheezing, or coughing up blood. Any of this been occurring lately? Any prior history of cardiac? So hematology. Ask your patients about any history of anemia, bruising, fatigue. With this, we're going to be going through a lot more of that in your medical chapters, but those are just some questions that you'll need to be asking. For the lymph nodes, see if they have tender or enlarged lymph nodes. Again, the patient will be able to tell you much sooner than you'll be able to see it. For your gastrointestinal, the one thing that we're really, really concerned about are any signs and symptoms that are pointing towards an active GI bleed. So any blood in the stool, are you vomiting up blood? And if there are blood in the stool, see if it's a coffee ground emesis or if it's a bright red type of blood. Genitourinary. These types of answers will usually not be freely offered, so the patient's just not going to come out and say it. But we need a question about their urinary habits. Are they going to the restroom enough? Have they been increased urination? And we also need to question about the genitals. Once again, they both secrete hormones. We need to ask about erectile dysfunction, and I'm seeing if it's on the next page. Nope. Erectile dysfunction, just because of some of the medications that we give. We shouldn't do that. So neurologic. We need to check and see if they've been having any seizures or syncope lately. Have you been having seizures? Have you passed out? Do you have any history of seizures? We'll also need to do a stroke scale on these patients. Psychiatric. Again, remember, depression or mood changes come with your psychiatric illnesses. Make sure on this one that you keep yourself safe, keep your crew safe. We also can ask about difficulty concentrating, anxiety, irritability, sleep disturbances, fatigue during the day, and suicidal or homicidal ideations. For clinical reasoning, differential diagnosis. This is where we're going to come up with that differential diagnosis. It is a working hypothesis of the nature of the problem. So when the patient first tells you their chief complaint and you start getting their history and doing an exam on them, you're going to come up with a differential diagnosis, what you think is wrong with them. And you're really going to be searching for answers to test that hypothesis. So your patient tells you they've been having chest pain for the last week. You do a 12 lead on them, you do cardiac things on them, and everything comes back normal. So we start looking at lungs, and they tell you that they've been having a little bit of difficulty breathing. One of the other questions you may want to ask them may be, do you have any headaches associated with that? So if it's a lung issue and they become hypoxic, they're probably going to have some headaches associated with it. So communication and empathy. Encourage responses. Be nice to your patients. Let them know that you're actually listening to them. Make eye contact with them. And put yourself in the patient's shoes. It's scary. I'm sure that everybody's scared when they call EMS. It's probably one of the worst days they've had in a long time. So work with the patient, be nice, and have empathy for that patient. Always ask your patient about their feelings. Are you happy? Are you sad? How are you feeling about this? So getting more information, we need to make sure to tailor our questions to the answers given to your previous questions. Again, where exactly does it hurt? So does the pain stay right there or does it move anywhere else? How would you describe the quality of your pain? So really, once your patient gives you an answer, you need to go that way with your questioning. Applying clinical reasoning, we have to be able to think and perform under pressure. So we have a very demanding job, and if we cannot perform under pressure, we're not doing our job properly. So getting history on sensitive topics, always be confident. If you want to ask a patient, again, who is 16 and you want to ask her if she may be pregnant, be confident about that. Because if you hesitate at all, you're going to lose trust. Alcohol and drug abuse. Just know that they're very, very, very good at hiding the signs and symptoms of their abuse. It's routinely understated. So if you ask somebody how much they've had to drink, it's usually going to be 2 beers when they've had a case. And usually these people will give you an unreliable history. Make sure that we're still professional with them, though. I mean, we know that they're going to hide those signs and symptoms. We know that they're going to lie to us. We know that they're going to give us an unreliable history. Just expect that and maintain professional. So, physical and domestic abuse. EMS must report physical and domestic abuse. Call law enforcement and keep yourself safe. Look for those unspoken messages, like a child who looks at their parents before answering any questions, or a wife who won't speak and only lets her husband speak. Any of those things can be an unspoken message. Usually when you separate the patient, though, as in you get them in the back of your ambulance by themselves, they'll usually start to open up to you a little bit more. So if possible, separate the patient, but don't put yourself in danger in order to do that. Sexual history. Keep questions focused. Asking about if a woman has abdominal pain, foul-smelling vaginal discharge, pain on urination, or genital lesions, you will need to know when the patient last had her period, when she last had sexual intercourse. So keep your questions focused and don't veer off that path into something inappropriate. We also want to ask about STD testing, if they've ever been tested in the past or when the last time they were tested was. Cultural competence. Be aware of your area. Know what religious beliefs and what cultures are there, and do some research on them. We have to be respectful of all beliefs. No matter what you believe in or the patient believes in, respect that. I know one of the things just off the top of my head was Jehovah's Witnesses, and they don't accept blood transfusions. So they will tell you that if they are bleeding for any reason or they're ever in the hospital, they will not accept blood. So some other special challenges. Silence. What do you do if your patient just won't talk to you? Learn how to time your questions and then wait. Really show the patient that you're there to help them, and don't rush the patient. And then you have the total opposite, which is your overly talkative patients. Always remember that more information is better than no information or less information. So if we can just kind of keep them on track of what we need to know, these overly talkative patients can help us out sometimes. Your anxious patients, do your best to calm them down and really help them trust you. Anger and hostility, do not put yourself in harm's way. So sometimes patients are just angry with everything. It's just something we're going to have to work around. Intoxication. These are my least favorite and most favorite, all in the same patient. They drive me crazy because you can't get any information out of them, and they're usually pretty unreliable and they lie. However, they're really fun to deal with. So just kind of, they're really entertaining. So just kind of go with it. Your crying patients. Usually, you can let them cry it out for a little while if the patient isn't too serious, but sometimes we're just going to have to get them back on a track, say, I can't understand you when you're crying, and move on from there. If your patient doesn't stop crying, you're going to have to go with a full assessment because you don't actually know what's wrong with them. Your depressed patients, they probably won't want to tell you anything. They're just, everything is wrong. So it's a little bit more difficult. Also, with our depressed patients, make sure that we ask about risk of suicide. All right, sexually attractive patients. I'm going to say one thing about it. It's never appropriate. Moving on. Confusing behavior. So if your patient is doing something that's completely abnormal or lying to you about something that they have no reason to lie about, they may be hiding something. They may have a change in mental status. And with that, you may want to contact their family and ask if it's normal. They may be having a TIA, trans-ischemic attack, little mini stroke. We definitely need to check their blood sugar. Anything else that can really cause mental status issues. Limited education or intelligence. Never presume that they have limited intelligence until you begin talking to them and they don't understand what you're saying. Use normal words. Don't try and show off with big fancy medical words. And always tailor your approach to these people. Family members will sometimes be able to help. Language barriers. Get an interpreter if at all possible, but make sure that interpreter does not share that information. Remind them of HIPAA. Children, unfortunately, usually become our interpreters. We want to avoid that if possible, especially in those really bad situations. You don't want a child interpreting their mother's death. That will leave them with some bad memories. So only use a child if it's the absolute last resort. So hearing problems. Never assume that they can't hear you. So don't walk up to the elderly man and start yelling in his ear when he could hear perfectly fine. So start low and then start talking up. One of the things that you can try if raising your voice just isn't working is you can put the stethoscope in their ears and talk into the bell of the stethoscope. That may help sometimes. Also, make sure that if they are totally deaf or have had hearing problems for so long that they're good at reading lips, make sure you stand face to face to them and you talk to them that way. Visual impairment. Let the patient know that you're always there. So if they're blind, what I like to do is in the back of the ambulance, just kind of keep one hand on their shoulder. So they always know that you're there and that you didn't just leave them. Also, if you go into the house and you have to move anything in that house, put them back exactly where it was. So if you have to move the couch to get them out, put that couch right back where it was. That patient has a path and has a habit of getting around their house. And if you move something, you may cause them more injury. Family and friends. Remember that immediate family is best, and the farther you get away from that patient, the less reliable that information is. Also with HIPAA, remember that we cannot tell any patient information to the family. The patient can say it all they want, but we cannot. All right, almost done here. Our pediatric patients. When we're doing a history taking on a child, always try and include the child. If not, at least let them be around when the parents are talking to you. We need to realize the parents are scared. So take that into consideration when talking to them. Don't be judgmental if they're crying or any of that. They're scared. We need to look at the child-parent relationship for a multitude of reasons. So the first one being, if this 2-year-old is clinging to mom when you get there and doesn't want to go to you, I'm not that worried about it being that sick. However, if the 2-year-old is holding on to mom and just willingly comes to me, I'm afraid that child is pretty sick. And we need to look at this relationship also for abuse or neglect. If the child, again, looks at the parents before answering any questions or just looks scared to be around their parents, we need to be reporting that. We need to look at the age of the child, look at their skin, ears, nose, teeth. Are Are they developing normal for their age? Oh, let me go back to pediatric for a minute. Oh, no. We'll move on to geriatric. Okay, so with your geriatric patients, just know that their senses dull. So they may break their hip and never even know it because their pain receptors are completely gone. Their sense of smell, their sense of hearing, sight, any of that, those senses dull. And a lot of times they have multiple issues. So their medical lists are just unbelievably long. And a lot of things can be causing the other stuff. Their medications. Really, really look at their medication list and grab their medications. I know recently my grandma was in the hospital or she wasn't in the hospital yet. She had just called me and said that she was feeling very dizzy. And she had started taking this new medication. And so I told her to run through her list with me, and she had 3 different beta blockers on her medication list. Because she had seen 3 different doctors who prescribed her 3 different beta blockers. So really be looking at their medications and catching those, because the doctors aren't communicating with each other, and we have everything there right in front of us. We want to look at disease symptoms. So elderly patients, they get diseases over and over and over again. See if those symptoms are what's causing the immediate issue, or if it is related to the immediate issue. Assess mobility. Can they stand up and walk? Are they bedbound? How is their gait? Can they walk around without falling? So really assess that mobility and how well they're doing. Okay, so that is the first half of chapter 13. Second half, we're going to go over the secondary assessment and our reassessment. So I will see y'all guys later.
My little Texas tornado blowing me away again. I swore it wouldn't happen again, but I looked at you and then I'm like a tumbleweed in a Wild West Texas wind.